and WT1 gene also activate with the GDNF. Now, I'm not going into the detail because this is complicated, but I just want to let you know each of these factors are responsible for various kind of genetic disease. If you look for the PAX2 complete mutation, you will have Potter syndrome. If you look into WT1, you have seen the patients with nephrotic syndrome and involvement of the genital organ. If you look into E by A, if you look into the RET, each of these chemokine factors, if you inhibit these gene factors, they have a tendency of producing some kind of a phenotype. And if you look into the ureteric bud, this is my favorite slide, how the genetically distinct zones have been defined within the cap mesenchyma, including the interstitial mesenchyma, and how these tubular aggregates goes on. Now, this is very important when you look into the bench side. It's what are the difference, or what is the difference between dysplasia, hyperplasia, oligomeganephronia, and renal agenesis. Dysplasia is abnormal, disorganized renal architecture. If you look about the hypoplasia, they are normal renal architecture with reduced nephron number and size may be dysplastic. There are conditions which we have seen, oligomeganephronia, which is decreased number of glomerulus with marked enlargement of those who are present. And this is a good example of a unilateral kidney where you see the compensatory hypertrophy, where you see the proliferations of the glomerular basement membrane. And renal agenesis is unilateral and bilateral absence of kidney, and that is lack of the ureteric bud combining with the metamesonephric parenchyma, and that is which I was telling you about the PAX2 gene and other chemokine factors. If you look for the dysplasia and hyperplasia, it's isolated dysplasia. Sometimes is associated with PUD, Eagle-Barrett. Dysplasia and hyperplasia is also associated with multiple genes like renal coloboma gene, which involve RET, vectoral charge, or Merck association. And Merck association has been defined that it has some involvement with the GDNF. That is a major component that combined with the RET gene through the ureteric and metanephric mesenchyma. Now, these are very important examples of some syndromes that we talked about it, like E by A1, which I was telling how it activates with the SIX1 genes, and through the WT1, it activates the GDNF, and that combines with the ureteric bud. So it causes renal agenesis and dysplasia and the brachioautorenal syndrome. If you look into the PAX2, it's renal coloboma syndrome. And GPC3, which I was telling you about the chemokine factor, you see Simpson Golabi-Behlem syndrome. I have only seen one cases so far, and renal agenesis with CAL, which is associated with Kalman syndrome. Now, what are the cystic disease? And this is important because it could be inherited and acquired and can manifest at any age from neonatal to much later in adult life, and it consists of single versus multiple cysts. It is a structural and the functional defect in primary cilia. It's fascinating how does the mechanosomes on the cilia is associated with the proliferation down the kidneys, and primary cilia have implicated in multiple signaling pathway, and one of them is platelet-derived growth factor and hedgehog and WNT signals. It's very complicated. So this is a paper which is coming in AJKD. I will highly recommend you all. I did it with Karsten Bregman and Siddharth. And this is the first time the AJKD took the pediatric genetic and sporadic renal system. And you can see how these cilias and various kind of genetic constitutions and proteins, and how does the primary cilia could lead with the centrosome the problem of the proliferation and cyst dysregulation. And you can see they have a mechanoreceptors, and I can go over and enumerate multiple genes, including nephrocystin, inversin, nephrocystin 3, 4, 5, polycystin 1, polycystin 2. There are some fibrocystin gene, there's cystin. But this is fascinating that one cilia method, which is in the setting of human, it's 9 plus 0 as compared to the non-vertebrate, if you look, it's 9.2, 9 plus 2 arrangement of the centrosome is the key factor of development of this syndrome or the cystic appearance. And this is a good example of transition from the cilia to the development of the cyst, renal cyst in ADPKD, and how does the tolvaptan or V2 receptor activation can cause the endogenous production of the renal cyst and accumulation of fluid. Now, this is how the model of a primary cilia structure is, and you can see what's going to happen is with the urine flow, what happens is it activates the central ciliary membrane, and you have an exome that goes to centriole, and that what happens is when you move with the flow with the mechanical receptors, you have an activation of the calmadelin that causes the activation of the calcium, and that helps in the cyst growth or cause proliferation. Very complicated and fascinating mechanism. And these are the structures of the polycystin 1 and polycystin 2 genes. You can see how this, if you get a gene sequence, you can look into it. It's a transmembrane involvement of polycystin 1, polycystin 2, and fibrocystin. And if you look at these are attached. Actually, the polycystin 2 are in the mechanical, it's in the primary cilia, and polycystin 1 also, you can see how they are present on the cilia, individual cell, and how they can help in the cell proliferation and growth. Now, is that the only thing that we are looking for? Is there any other factors that we are looking for? So this is our first transitional paper. Actually, we figured it out that urine endothelin is also contributing the surrogate marker for the endogenous production of the endothelin. Maybe the endothelin will be leading to the production of the cyst, and that came out to be true. This is our paper which is published in Nephrology, BMC, where we have shown the patients between 18 to 53. And it is fascinating to see that the GFR is negatively correlated with the endothelin in the urine. Now, urine endothelin marker is very surrogate. It has nothing to do with the serum because you take it with endothelin divided by creatinine. So it's a very good tubular estimation of the endothelin. And then it is positively correlating with the total kidney volume. And then you can see the quantile, if you look how the urine endothelin quantiles are associated with the renal growth. And definitely this was something which we looked around, and then we had a paper that we published, maybe endothelin 1 will be a therapeutic target in the autosomal dominant polycystic kidney disease. And we found out that ETA1, ETAR and B is responsible for cell proliferation, and ETA is for the contraction, for ECM accumulation, maybe the mechanism that we have to hamper. Also, there is a role of VEGF, which I'm sure Jalala is going to talk about it. It's also a very important factors in the growth of the kidney cyst, and it increases the endothelin level. And same as VEGF2, it causes the capillary surrounding the cyst. It causes the cell proliferation, more vascular involvement. And definitely we have seen also VEGF2 present in the interstitium. So we are working on this. And then maybe this was the therapeutic targets. Are we working on mTOR? Is mTOR responsible for cyst production? Is it the cyclic AMP? Is it the B2 receptor? Was it the polycystin 1 and 2? Was it a VEGF? This is what I was dealing 11 years ago when I have a human transitional setup of the basic science going from the animal to the human. And it was complicated structure because these cysts are individually very proliferative, very active. They act like a whole cell. So we were in between, is it the endothelin, which we have shown in the transitional from animal to human, that shows that endothelin is positively correlating with the total kidney volume. Can we block the endothelin receptor A and can diminish the production? That could be a possibility role. I was never under the impression that vasopressin could be so strong to affect and can help. So these are the potential markers you have when you work into the basic science and you want to inhibit the growth of the polycystic kidney disease. Classification was a big issue. This is a paper in Journal of Maternal Fetal and Neonatal Medicine. And this came out to be a complicated classification. Are you going to classify these genetic diseases on the basis of their genetic inheritance, or are you going to do that on the basis of the clinical features? I prefer not to go with the genetic gene locus or protein involvement because I'm a clinician first, then a basic scientist. But in our lab, when you look into these patients, you need to classify on the basis of the gene locus. Like example, NCKD, you have to look for UMOD gene. Are you looking for juvenile nephronophthisis? This is NPH. NPHP1, tubular sclerosis. We had a nice paper on tubular sclerosis and interaction of the gene with the VHL. And then one hippolympho disease is at VHL 3P226. So, or you look into the clinical features and classify them on that basis. Then we have this was published in Journal of Clinical Nephrology. What I prefer, I like to do it on the basis of the autosomal recessive versus autosomal dominant. Is it a sporadic? Is it miscellaneous cause? Is it inherited disorders associated with polycystic kidney disease? And that's the way I classify it, because it helps me in genetic counseling to label these kind of cystic disease into several categories rather than going into the gene locus and looking into it. Now, this is another one which I have used a lot, like looking into the renal tract abnormality and the polycystic kidney disease or ARPKD, or you're talking about the chromosomal aberration. Where is the renal cyst? And how much is the percentage? Are you looking for moderately large hyperechoic kidney within DCMD, normal amniotic fluid, uncommon associated malformation, then you're dealing with autosomal dominant polycystic. If you're looking for ARPKD, you have enlarged hyperechoic kidney, absence of CMT, oligohydramnios, uncommon associated malformation. Are you looking for Meckel-Gruber? And I have 3 or 4 patients with Meckel-Gruber syndrome, medullary cystic dysplasia, severe oligohydramnia, CNS abnormalities, occipital defect, polydactyly, enlarged hyperechoic kidney with portal bead and absence of any CMT, and do you see any digital abnormality? So this is another paper that we published, and actually Siddharth came up with a nice algorithm that if we are dealing with the patients with hyperechogenic kidney, and if you have exclusion of the simple renal cyst, multicystic dysplastic obstructive dysplasia, then you look for the family history, ultrasound examination of the parent, genetic counseling and karyotyping. And then you look if you have no associated information, you're dealing with polycystic kidney disease. And if you have ARPKD, you have the cyst of like cortical cyst, you have a kidney size flaw, +1 to +5, standard deviation, family history positive. If you're looking for ADPKD, then you have a cyst both in cortex and in medulla, and you have variable corticomedullary differentiation and amniotic fluid diminished at around 78% of the patient. Kidney size goes from +1.5 to almost 15. And if you're looking for syndrome, do you have polydactyly with renal cyst? Then you're dealing with Bartle Beetle or Beamer. If you have occipital deformity, Merkel, MG, Meckel-Gruber syndrome with Danny-Rackelbaum formation. If you have thoracic or spine malformation, then you have Jarko-Levine or Beamer syndrome. So this is a kind of a clinical approach when you look into the renal ultrasound and associate what kind of renal cystic disease are you dealing with. This is our paper in AJKD core curriculum. This is, I really like the pattern in the ultrasound. Are you dealing with bilateral cyst or hyperechogenicity without oligohydramnios? What are your differentials? What is the bilateral cyst or hyperechogenicity with oligohydramnios? If you have a solitary renal cyst, what are you dealing with? If you have multiple unilateral cysts, then it is, what are the differentials? So what I personally use is I use the renal ultrasound criteria and then put into the clinical perspective, which we have published, like how can you look and how can you classify these patients in the genetic paradigm. Incidence, ADPKD is 1 into 600, ARPKD 1 in 20,000, nephronophthisis, I see a lot of population that have typical inheritance of nephronophthisis. Joubert syndrome, I have 2. 1 in 100,000. Bartle Beetle, I have 3 or 4 patients. Meckel-Gruber syndrome that I showed you about, the occipital defect. I have 1 patient, an orofacial digital syndrome, OFD1. Now, again, if you look these kind of syndrome, how you can see the interaction between the ureteric bud and the mesenchyme and metanephric bud, and the interaction with GDNP using PAX2, using the SIX1, using the various RET gene, how they interact and how these cysts or this agenesis. And so this is key for you to look for the ureteric bud and mesenchyme or metanephric bud association. Let's do some cases to make it more approachable. We have this male fetus, left hydronephrosis and hydroureter on prenatal ultrasound, patient born at 7 week, APGAR 9 and 9, postnatal ultrasound shows left hydronephrosis and hydroureter. And this is a normal renal ultrasound. In postnatal, you said some kind of fetal lobulations in the kidney. And this was his kidney. Like, it is a primary non-obstructive, see the ureter, huge, non-obstructive, non-reflexive megaureter. It was unilateral. And basically what you do is you do the VCG diuretic renal scan, and see the ultrasound often improves over the first few years of life, and then patients, they just grow out of it. You may have to prevent any kind of surgical complication and see there's anything going on with that. So just kind of give you an example. This is another case, male fetus bilateral hydronephrosis at 18 week of oligohydron was noted by 28 week, delivered at 28 weeks, immediately developing respiratory distress, absence, abdominal. This is a muscle. This is Eagle-Barrett syndrome. With prune belly syndrome, now we call this as not Eagle-Barrett, we call it as prune triad syndrome, which you need to have absence of decreased abdominal musculature, dilated ureters, undescended testes, and also associated with cardiovascular problem. Case presentation, G1P0 female, noted to have prenatal ultrasound to have polycystic kidney disease, no oligohydramnios was seen, family history was unremarkable. At term, female infant was delivered without any complication. Postnatal ultrasound was performed at community hospital, showed multiple cysts in the right kidney, which did not seem to be communicating with each other, which is a key factor for multicystic dysplastic kidney. And that's what I was showing in the beginning for transition from bench to the bedside. Is this is classical of MCKD, and it's again, it's a lack of abnormal connection between the ureteric bud and metanephric blastema. Second most common cause of flank masses, and they involute, and 20 to 30% of the chances you have the PUGA involvement on the good kidneys, and they resolve in 2 to 5 years, and sometimes you get blood pressures, and see how the MCKD displaying multiple large cysts and how they're not connected. So this is 31-year-old G2P1 Mediterranean female with a history of consanguineous marriage, uneventful first pregnancy, 13 week, both kidneys look bright. At 20 week, they were found to be large hyperechoic, and 27 week, there was a severe oligohydramnios. Again, the rule of cyst appearance, associated genetic abnormality, and what is the clinical presentation. And the ultrasound image shows bilateral, markedly enlarged kidney with increased medullary echogenicity, and this was ARPKD. Incidence 1 in 10,000 to 1 in 40,000. And it is due to the mutation in PKHD1. It's a very large gene. It has at least 68 exons and multiple alternative transcripts that encode fibrocystin. And what they have found out that these mutations throughout the gene, only few of them, they have a hotspot that identified. And you find a large kidney with complication of hypertension, renal insufficiency, hepatomegaly because of the fibrocystic involvement. Now, other abnormalities, you see oligohydramnios sequence or massive kidney enlargement, pulmonary hypoplasia, and that pulmonary hypoplasia is one of the determining factors for the patient's morbidity and mortality, and you get hip contractures, clubfoot, sometimes Potter's fascias. This is a paper that when you have to diagnose ARPKD, history of affected sibling, lab or pathological features suggestive of hepatic fibrosis, very specific. Parental consanguinity is suggestive of autosomal recessive inheritance, absence of cyst in both parents. Grandparents, if the parents are less than 30 years of age, this is your diagnostic criteria at the bedside for diagnosis ARPKD, and they can mimic like pyelonephritis, radiocontrast nephropathy, bilateral renal vein thrombosis, you name one, because you don't see the MCD differentiation. Bilateral symmetrical renal involvement, you see large echogenic kidney with poor corticomedullary differentiation, and you will discrete macrocysts macrocysts are usually absent. Those small cortical cysts may be seen, which is different than ADPKD. Gauss appearance of ARPKD, this is one of my patients' specimen, the renal pelvis and calyces are dilated. But again, going from the bedside, from the research to the bench to the transition, what are you going to tell to the patient? So this is a nice paper came out in Frontier in Pediatrics and Journal of Pediatric Nephrology. This was with my mentor, Catherine Dell, who has a special interest in ARPKD. We looked into the data on the CKID, and we found out that the annual GFR change in subject with ARPKD was minus 1.4 with a higher decline in subject more than 10 years. There were no significant difference in the hypertension, left ventricular hypertrophy rates, but subjects with ARPKD had a higher percent on 3 blood pressure medicine, more ACE use, And children with ARPKD and mild to moderate CKD and CKD cohort have a higher prevalence of growth abnormality, but these are similar to the children's to other congenital cause of CKD. It's very good to give a talk. When you talk to the family, they want to know what's going to happen. If I get this, what is the involvement of the liver? So this is a counseling skill for you. This is another case presentation. This was a real one week. All of them are real one. This was a real one in the sense when I was a pediatric fellow, came out, and then the baby her mother was evaluated prenatally for finding a large echogenic kidney in the fetus. And when we talked to the mom, she said she has never had any history of any cysts. You can see multiple cysts are seen in the right kidney. And there are around like 6.5 cysts on the ultrasound. Echogenic, mildly enlarged kidney with several macrocysts consistent with polycystic kidney disease. Now, these are not, they are communicating, but MCKD is a huge, large bag of balloons with no communication, no renal parenchyma. If you look into the ARPKD, slightly the echogenicity is as much as of liver, no macrocyst. It's just plain huge kidney with no CMT. So this is what you have to keep in mind. And again, the complications are ESRD, hypertension 80%, 20% have symptomatic polycystic liver disease, 1 to 2% ruptured intracranial aneurysm. And early presentation sign is usually in hypertension, and it tends to manifest early in 10 to 15%. And this is the difference between ADPKD and ARPKD. The mutation, the most important thing is macroscopic renal cyst, usually asymmetric in distribution. ARPKD enlarged echogenic kidney, oligohydramnios, dilated tubules. You'll see the dilatation of colic collecting that oliguria. And in ADPKD, you see the corticomedullary cyst involvement. Now, if you see, this is how the cyst looks like, fluid cells. And again, the genetic testing and genetic involvement, polycystin 1, polycystin 2. Now, this is not true that only 10% of the people have lacked the positive family history. If you look into our database now with the study, it's actually coming around to be 15 to 18%. And molecular testing is available. Variable accuracy depend on the number of affected and unaffected family members, and you look for mutation analysis. You can also do a pre-implantation genetic diagnosis, which is available for the families. And PKD mutation may be difficult to detect due to the large gene size, technical issue, but current method can detect around 85% of mutation. Now, this is a reveal criteria, which is application to the age of 15 to 39. If you have more than 3 unilateral cysts or bilateral, 40 to 59, more than 4 and 2 in each. Now, one thing you have to remember, ultrasound is the most commonly used imaging modality for ADPKD. And for equivocal for US ultrasound results or disease exclusion with high certainty, MRI may be used for age 16 to 14 if you have more than 10 cysts in MRI is diagnostic. Less than 10 cysts rule out ADPKD. And CT scan, I'm not very much inclined towards, but MRI pick up more microcysts, which is an evolution in the kids or young adolescent. Now, what is the pathogenesis and development of the PKD or polycystic kidney disease? Because mutation leads to defect in PC1, PC2, then cyst formation due to the epithelial self-proliferation. Fluid causes cyst to balloon out and pinch off from an individual nephron. Normal renal parenchyma is displaced, and you see multiple cysts in the kidney. Now, this is my slide when it was given to me when I was in a training grant. What is causing the polycystic kidney disease? Is it the disrupt flow sensing and tubulogenesis? Is it the cyclic AMP that we are talking about causing the proliferation of the cyst? Is it vasopressin? Is it the proliferation and differentiation path involving the mTOR, including the NFK, or is it a fluid secretion due to the chloride channel, how the cystic fibrosis occur? Now, this is a good slide that I hope I can put it on. This just define my 11 years of research, but a beautiful video to show how these things evolve in inhibiting the vasopressin cyst in ADPKD, derived predominantly from the AVP sensitive tubular segment, AVP acting on V2 receptors, the main hormonal regulation of the adenylyl cyclase, and that circulating level of AVP are increased in human ADPKD, and cyst cells, they persistently get stimulated. And this is how the GnRQ works, which is the tolvaptan, and it's vasopressin bind to the V2 receptor, decrease cyclic AMP, reduce cell proliferation, slow kidney function decline. I can say that with a lot of pride that this was the best thing I have given back to the pediatric or to the nephrology world, because we were not sure that this will be going to be our what you call that a break point, that V2 receptors can be such a pathognomic of the cyst growth. Then you have to look for the predictors of the rapid ADPKD, because, and Jalalia is going to talk more. You cannot give tolvaptan to anybody who comes and walk in with one cyst or two cysts. They need to have a progressive ADPKD. That's what FDA approved. That's what we have given our data to. And you have to look for imaging predictors, you have to look for clinical predictors, you have to look for genetic predictors. And this is how the slide works. You have to look into the total kidney volume, age, calculate, and classify. And we have actually this model where you can assess what will be their slope in the GFR. If you have a rapid progressor, if you're a less rapid progressor, or you are intermediate or slow, I will recommend you all to look into the calculators in QXMT, where you can use a renal length, breadth, and height, and convert it into the total kidney volume, and put your patients into this kind of a curve to see whether they are rapid progressors or not. Reprise and tempo. Tempo was done. We went to the FDA. FDA said, no, we are not going to take this medicine. And they were right, because if your tempo trials were all cherry-picked patients with a normal creatinine clearance, more than 60, and now we have done this reprise trial, which has patients from 18 to 55 years, and they are from GFR of 25 to 65. I have enrolled a patient of GFR of 25, and I have so much of stories to tell with the time commitment. I'm not, but they got 4 or 5 years without dialysis and transplant, and 49% reduction in the rate of change of total kidney volume at the end of 3 years. A lot of the people have said why that after the 3 years, it didn't change much. Well, this is an allosteric inhibition. Once you inhibit the V2 receptor, the difference in the TKV treatment group mostly developed within the first year. The early assessment was a little further difference in 2 to 3 years. And tolvaptan has little effect on the kidney size beyond what occurs, because if your kidney size doesn't go down, or at least go up, or doesn't reduce after 3 years, means the drug is not working. So that was tempo trial. And then this is 26% reduction in rate of kidney functions decline from patients with enrolled more than age of 18 years, 35% reduction in decline of kidney functions compared to placebo. This is a paper in the Nature Pediatric Research. And my frustration was that even we didn't have any data, and we came up with the guidelines for the treatment of polycystic kidney disease that was published. And I was reviewing the paper, and everything is like, you don't have any data in pediatrics. You do not. So this was instigated by that Nature publication, and we looked into our Tempo 3-4 trial. We have 51 patients from the age group of 18 to 24, and see the response. The mean change in TK, change in the total kidney volume growth per year was 6.5 in placebo, 3.9 in children's or adolescent, or AYHA, adult youth with a health condition. And 25 to 50 was 2.7, 3.9. And see the ALT, AST, there was no liver involvement in the setting in children's as compared to 4.5. You combine the tempo and the reprise together, causes the transaminitis. So this is a beautiful picture of placebo versus tolvaptan's, the kidney size, the hematuria, systolic blood pressure. So this is the only data you have right now for the adolescent, if you have an 18-year-old, to write the medication. Rest is all a speculation, rest is all under the trial, rest is all guidelines. So and in US, if I have to prescribe a medicine, I need to prove to the patient, this is what the efficacy is. And this is being used, and a lot of people are prescribing the medicine now, 18 and above. This is another paper. If you look for bench to the bedside, is heart and the kidney involvement, renal aneurysm, sorry, the cranial aneurysm, how to assess, what are the things you need to do for the blood pressure of these patients, whether you should give ACE or not. Don't give them the calcium channel blocker. ACE is good because it has shown some effect on endothelin and effect on the kidney progression. Liver disease management is another big issue that you have to deal with. Sometimes these patients have a high risk of the infections. And again, prognosis, you need to sit down with the family and say, here it is, what is your genetic mutation? How would you going to progress? What's going to happen? Although data about early onset ADPKD are limited, recent studies suggest that prognosis may be more favorable than expected. I will end my slide with this, and when Rajiv asked me to do this, Rajiv knows this is my area of research that I have done. This is not an easy journey. And I believe me, when people have told me that this tolvaptan is going to work, I was like very skeptical and see what that most of these cysts, if you take a human ADPKD, they're loaded with V2 receptors. Preclinical models may not predict the clinical efficacy, difficulty in assessing the biological efficacy. There's no way you can assess. Long natural history of disease is a problem here. Age-related decline in GFR, acute effect of drug on GFR, lack of sensitivity, early clinical biomarkers, which are acceptable for the FDA's endpoint, long-term tolerability, need for the drug efficacy. This is a problem when you go as a clinician from a research to the bedside. You need to transform. Not only that, you need to assess, you need to make sure that you are doing a feather approach to the patient. So these challenges, this is my story for almost 19 years here. I did med-peds, I did nephrology, both at and peds. Jalala was asking, I said, welcome to my world. If you have any problem, you can ask my wife. 11 years of training. But what you learn with this assessment, you give back to the community. And it is a safe medication. I have a lot of patients and adolescents on this medication. I'm sorry, I'm a little bit over the time, but I'll give the podium back to Rajiv. Rajiv, thank you for inviting. And Rajiv and I have been working on some of the collaboration, and Rajiv is a very good friend of mine. And has been very, very academic and has been involved in a lot of research. With that, I will defer to Rajiv, and so nice to see Sushmita and some of the friends from India, and nice to meet with Jalala.
Thank you very much, Rupesh. So I think without wasting time, we'll go to the second speaker because we will take the question at the last. So Dr. Jalila, she will be speaking on, concentrating on childhood onset ADPKD, and maybe trying to give us some clues where there are none. So Dr. Mekali is a pediatric nephrologist in Belgium, and she has a deep interest in cystic kidney disease. And she is leading one of the part of this European consortium on cystic kidney disease. So it's all over to you, Jalila.
Do you see my slide now?
Yeah. If you can just make it.
Yeah,
full.
they don't want to wait. I'm gonna do it again. Sorry for that.
Yes.
Yeah, perfect. Okay. Good. Do you hear me good? Well,
Yes. Yeah. Okay. Fantastic.
Thank you very much for inviting me in this faculty lectures series in Calcutta. I am really very pleased, and I would like to thank Rajiv that he remembered me, because we were fellows together, I think in 2008 in Great Ormond Street Hospital, where we spent there a year together and we worked together. So I will present you and I will try to answer the question that Rajiv sent it to me. Why should pediatrician bother about AD-PKD? I think we had a very nice introduction to the topic with our colleague Rupesh Raina. And I will try to convince you that as pediatrician, we really need to move forward in this topic. So I would like to go briefly on the introduction because it has been done already by the previous speaker. I would go in depth in the pediatric spectrum of AD-PKD, try to elucidate the management and the current management of these patients and speak about the perspective. And I will introduce you to my new adventure, the AD-PKD registry. So because it was asked to me to keep it clinical, so I have only really a clinical presentation. However, if you are really interested in research and what we are doing in the lab currently, you need to invite me again. So as my previous speaker told you, AD-PKD is the fourth common cause of renal replacement therapy worldwide. And actually the main genetic diseases for end-stage renal disease. The main mutation are, of course, PKD1 and PKD2. However, more and more other very rare patients with a more mild phenotype are getting elucidated. And we have recently 3 new genes who were published by the group of Torres, the GANAP, the DNA GB11, and ALG9. So just to think about it, if you have a familial with a PKD phenotype, but with a very mild and with few cysts in the kidney, but sometimes with actually more cysts in the liver. So it has been also shown that there is a genotype-phenotype correlation as patients with PKD1 and more specifically the ones with the PKD1 truncating mutations have a severe phenotype comparing to the non-truncating, comparing to the PKD2 mutation. And of course, it has been demonstrated that end-stage renal disease reach only at the age of 50, 60, according to the genetic background. So it is stated, and sometimes it is actually used, the term of AD-PKD as an adult polycystic kidney disease. However, and because it is relatively polysymptomatic during the first 3 decades of life, however, I think we are just seeing the top of the iceberg. And the children are having indeed a normal or a mildly decreased GFR. However, it is a delusion because there is an hyperfiltration phenomenon and the hypertrophy of residual nephron, which afterward decrease very rapidly the GFR. And Grantham wrote a very nice review in pediatric nephrology, stating that actually the first cyst in AD-PKD is already prenatally present. So it has been described that 2 to 5% of the AD-PKD patients presented already in childhood with a broad phenotypical spectrum of the disease. And many doctors are thinking that actually this disease really don't be to be followed in pediatric ages. So the main question that I am confronted to, certainly in Europe, should we test children in families with positive history of AD-PKD for the presence of the disease? And actually there is a very big medical controversy which divides 2 separate groups, the pro and the contra. And why is the pro and the contra? So the healthcare givers who are contra the non-testing the PKD, because they are telling us there is now no effective treatment. If we make a diagnosis in childhood, these children will have problem getting work or getting even their insurance, and also that we are getting them stressed, medicalizing them, and however that they are now currently healthy individuals and they can live their childhood without any burden. The healthcare givers who are protesting are stating that we might treat modifiable aspects, because these children might present with hypertension or proteinuria, and these are really treatable, and we might maybe change the prognosis. The second, we know that if we have a very severe childhood form, that there is a recurrence risk that the other family members have also a severe early form. And also I am seeing in our clinic that some parents are really, really stressed because they want to know if they have given the disease to their children or not. So till now, and I think my colleague, my previous colleague already demonstrated very nicely that there were very few or no guidelines available. The pediatric data are really very scarce, and the available data are really from a small cohort, making us really in a difficult case that we need to prove our need to treat or to follow up these children. However, the new pediatric community and the new tendency, we are changing really our thoughts, and we are trying to highlight that this disease is not only an adult disease. So this was actually one of our main topic with my previous PhD students, where we made really very nice views on the literature, that we need to look to the pediatric perspective in ADPKD, that ADPKD is not an adult disease, but is more and more becoming a pediatric disorder. And we have now a review which is in press in pediatric nephrology with Carson and Charlotte, where we are stating all the novel management changes in ADPKD in children. And I'm gonna go through this new review. So I think Charles Darwin said that a fair result can be obtained to teach the controversy only if we have really facts. And if we be honest with ourselves, we don't have enough facts to convince this active screening of these children. And that's why we need, as pediatric nephrologists, to work all together and to prepare these facts to convince that we have a role to play in this disease. So I would like really to highlight that indeed the main patients will only have end-stage renal at a later stages at the age of 60 years. However, we are seeing more and more children with early childhood onset, and I am following few children that they will reach end-stage renal disease by the age of 30, and with a very early onset with prenatal huge kidney, already cysts prenatally, who reach actually the end-stage renal disease by their 20. And we are also seeing in our clinic this broad PKD, ADPKD spectrum, where one part are coming to us with parents who would like intentionally to test their children, and they want to know if their children have the disease or not. We have a second group who are seen in our emergency or in our other clinic and for other reason, for abdominal pain or something like that. And when they get an ultrasound done, we find incidentally this renal cyst. And you have the main group which presented in our clinic already with symptoms such as hypertension or hematuria. Till now, they are really not clear how we need to follow up these children and how we need to deal with them in our clinic. So comparing the incidence of the symptoms of the children to the adults, you see here that Arlene Chapman have this review in pediatric nephrology. And you see that the children have also already hematuria, concentrating defect. We see them sometimes in the clinic presenting with enuresis, or sometimes you have new children who came for enuresis and doing an ultrasound, we diagnose AD PKD. Proteinuria, albuminuria is also from 20 to 30%, and actually the main symptoms is hypertension till 44%. More interestingly, the group of Colorado, Melissa did really a lot of work on pediatric AD PKD, and they were even able to show that in AD PKD, because as you know, it is not only a kidney disease, but a multi-organ disorder, which also affects the kidney and affects the blood vessels, that even with borderline hypertension, that children might have left ventricle hypertrophy. We performed also a European study including almost 300 children, and we did an ABPM, and we showed that more than 35% have hypertension, but what was very impressive is that 52% had this non-nocturnal dipping, as we see actually in population with diabetes or with obesitas, and 18% had an isolated nocturnal hypertension. Of course, again, in this case, we don't know what to do with these children. Should we already treat them? Should we already start ACE inhibition? There are no RCT available, and we don't know because we still need really fact on our management. So Marley from Great Ormond, from Great Ormond or from Evelina Hospital, did a meta-analysis on all the study performed in childhood. And you can see that in 509 children were actually published in all the studies together, and with a confirmed AD PKD, and he demonstrated that the proteinuria was present in 20%. We know from our experience as pediatric nephrologists and in other diseases that proteinuria is a marker for chronic kidney disease, and that it is responsible for a further renal damage and fibrosis, and that we should go and start directly with ACE inhibition. However, again, no RCT available in CKD children, and certainly not in AD PKD. So recently, during a meeting here in Belgium, in Leuven, we wrote actually a consensus with a lot of stakeholders of AD PKD, including adult nephrologists, pediatric nephrologists, radiologists, but also patient representative and geneticists. And I must say it was a very challenging discussion to find out all what we have to do and should to do. So we tried to summarize all the questions in regarding the management of AD PKD. And more recently, we were invited from pediatric nephrology to make a review analyzing this consensus and highlighting the most important points, and making it easy for a pediatric nephrologist who see a patient with ADPKD and to help how we need to deal with it. So we tried actually according to the current literature and according to this international consensus to draw an algorithm that I'm gonna through it with you and guide you, because I really use this, and it was based on my own experience, as I have now an AD-PKD dedicated clinic for children, and I am following almost 100 children in this clinic. And I made it really with our experience here in Belgium. So when I have a patient asymptomatic coming to my clinic with a family who have actually a positive familial history and a clear history of polycystic kidney disease, my first clinic is only talking. I don't do anything. I just discuss the pros and the contras of diagnosing the disease. When the child is mature, then I discuss also with him, and I discuss actually the pro contra. I send them home, I let them think about it, and then I see them again in the clinic and make and hear from them what is their decision and what is their opinion. So, or they will say, we don't want to diagnose and we don't want to know. Then I make it clear that it's still that the child have a risk 1 in 2 to having the disease, and I give them the advice to continue doing proteinuria check and blood pressure check. However, I don't push for the diagnosis, as I respect their choice. If they want the diagnosis, then we have actually 2 options. Or we can ask for an ultrasound screening. However, if there is negative and there is no cyst, so you cannot exclude the disease, and you might actually think doing the genetic testing if it is available. If it is not available, you need to follow up with a regular ultrasound. If you see already a cyst, then you have made the diagnosis of AD-PKD. As my colleague just say, there are really no radiological based diagnosis under the age of 15 years. However, with our consensus paper and discussing with renal nephrologists, we think if you have a child younger than 15 years with a clear familial history, if you have 1 or more than renal cyst, it is already highly suggestive to have the disease. When you have a fetus or a neonate with hyperechogenic enlarged kidney with a clear familial ADPKD history, it is also highly suggestive for ADPKD. The question raised also, if you have this ultrasound negative, how frequent should we repeat? And here we just said 3 years, but I mean, it was really an opinion, an expert opinion, not based on study or nothing. So if you don't have the genetic, then is it actually you need to look with the family and with your clinic how you're gonna manage this. If you have the genetics available, that is the most easy and straightforward answer, because you can give a clear answer to the family. If it is negative, you discharge the child and you don't see him anymore. If it is positive, then you have actually the diagnosis of AD-PKD. So in our consensus paper, of course, the more experts were not agreeing on doing genetic in all the AD-PKD children, because it is not available in all the countries. In few countries, it is really very expensive. However, we agreed that when you have an early onset with AD-PKD VU or a really severe AD-PKD, we should do the PKD. However, think about it, because sometimes, like Carsten Bergman published few case reports that with very severe ADPKD, you may have inherit the germline mutation of the parent, but you might have a variant from the PKD or from other ciliopathy genes from the non-affected parent, and this hypomorphic gene will be actually responsible for a severe phenotype. So in these children, beside the PKD1 and the PKD2, mainly we add also the ciliopathy gene panel to try to explain the phenotype. And like Heine say, it is important for this young couple for the second pregnancy, if they want to go in PGD, then helping her elucidating the genetic phenotype of their severe child is very important. So then we have a population that we are seeing in our, or they are referring from a general pediatrician, that they get children in their emergency room because of something else. And then they have this incidental finding of PKD, and you have either a known familial history or a negative familial history. So if there is a negative familial history, you can do the workup of cystic kidney disease, like it was very nicely explained by the previous talk. However, you need to think to the de novo ADPKD also as suggested 10 or not more % of the population. If it is a familial history of ADPKD, the diagnosis is much clearer. So when these patients are presented to your clinic with the ADPKD, so we measure the blood pressure. If the child is older than 5 years, we do always at least once an ABPM. We try to target the treatment and to reach blood pressure already above P90, because our aim is to get a target blood pressure under or tussen P50 and P55. So we are there really very careful to decrease the blood pressure more than other population. And of course, as it has been highlighted, the first choice is ACE inhibition. Second, if your child have proteinuria, we need actually to start also very early ACE inhibition. And we mainly do it screening in the clinic with dipstick or with the urine. However, to confirm our diagnosis, I do always 24 hours urine collection, because when you have quantified the proteinuria, you can better follow up this and certainly follow up the effect of your treatment. The non-pharmacological management is getting more and more important, so we need to be very careful, because as you know, ADPKD, the main cause of mortality is more cardiovascular, and we try to advise to maintain a healthy body weight. The frequent water intake, it is not yet proven. And I think the last week or the last things in NDT, there is a very nice paper on the value of drinking lot or drinking less in CKD already. And there is now also currently studies going on to study the effect of water intake in ADPKD. I already starting educating them with salt restriction, with regular exercise, as we avoiding caffeine and smoking. So I worked with the PKD International on and with the European ADPKD Forum on this ADPKD route map, and I would really advise you to go and to upload it. So you can upload it in the iPhone or in a tablet, or you can also see it in in the computer. And actually, it was mainly made by the PKD International Foundation, and it is mainly made for patients. And you can actually advise your patients if they are curious and if they want to know more about their disease. There is really almost everything explained on the disease, on transplantation, on dialysis, but also on basic management and self-care, and on sport, food, everything. So I would really advise you to go and have a look on this AD-PKD route map. So I'm going to just introduce, because my previous speaker already spoke a lot on tolvaptan, just to let you know that I participated in the first trial in pediatric tolvaptan treatment, where we have almost 100 subjects treated with tolvaptan, with first year randomized double-blind tolvaptan placebo, and then 2 years open label. And we are now analyzing the first year of the treatment, and you will be very surprised with the results. So we are writing an abstract, and you will hear soon from our results. And then I'm gonna introduce my new passion and my new adventure. I had this crazy idea in 2017, because there are a lot of registry in adult AD-PKD, and these adult trials are always using numbers of 100. However, almost all our research in AD-PKD children, I think the biggest cohort that we published is this 300 European patients, where we did only ABPM. So I made the challenge to start with a registry on AD-PKD, and I start very modestly in my own hospital, and then I convinced the friends, and then I convinced the colleague, and now actually was the aim to be worldwide. And the aim was to generate data on the incidence and the presentation, to define a pediatric scoring system, because it will be very challenging for us when there is effective treatment in AD-PKD, that we need to select and stratify patients who need to be treated and who are at high risk, because if you have children from families with a PKD2 or with a GANAP with a very slow disease, with a risk of end-stage kidney disease at the age of 80 years, we don't have to border them. And there I think I totally agree. Also, I think we need really to follow up these children that we are treating early for their hypertension and proteinuria, and where we are giving this ACE inhibition, because there is no study ongoing on this effect on long term. And finally, to provide some international guidelines based really on fact. So the registry is actually very nicely done. So you have actually the basic data, where we ask for the familial history, the personal history, then the genetic, and how these patients are initially diagnosed. Then we start with the first initial visit that the patient presented to your hospital, and we build in with a prospective data with your yearly, or however you are following these patients. So I would like to let you know that these numbers are growing really daily. Now we have 89 centers doing with us from 33 countries, and we have now almost 150 patients included. I must say, my contact in India was, of course, Rajiv, and I was really very delighted that he accepted to join me in this adventure, and he have already succeeded to include 4 children. And I hope that after my presentation today, that you will all join this adventure, and that Asia and specifically India be part of this very nice project. So the numbers are really growing daily. And I have now a PhD student working on it, Angelique Dashi, that you can actually always reach us. So you can go to the website adpetkd.org and you can register, or you can just send me an email and we can help you if you are interested. And I think Rajiv is also the person who will be the representative of this registry in India, so he can also help with everything. So we published actually already the methodology, which is available also on the website. And we are aiming to do the first analysis of the first data in March of this year, where we will actually already analyze the first 1,000 patients. So as I told you, we have also a really very big translational PKD consortium where we are having currently 4 PhD students working on cellular and animal model, 4 technicians, and lots of interaction with other specialty. So if you are interested for more our research and what we are doing, I can certainly come back and give you another talk. And I would like to finish thanking also all our collaborators from the whole world. But mainly, I would like to thank, and I am always emotional when I see this picture, all the ADPKD children of my clinic. Here we make an art day when we prepare the symposium for their parents, and each child had to illustrate his kidney, and I am very proud of this artistic work. And I would like to thank you for your attention.
Thank you, Jayla. That was really excellent. And as usual, it ended up generating more questions. And that's what a good lecture should. We will take some of the questions for the next 10, 15 minutes. We'll first go through the chat box, and then we will open the discussion to the rest of the panelists as well as to the attendees if they have any questions. So the first question is for Rupesh. Rupesh, you are there, right?
Yes, I am. Actually, with the email, I logged myself as under your name. As I'm driving, so that's the reason.
Sure, okay. So what is your advice for a prenatal diagnosis of a bilateral large hyperechogenic kidneys without family history?
So I have like 3 patients with that, and one of them, they actually turn out to be, 2 out of 3 turn out to be ARPKD. And when you're seeing that with negative history, your probability of having that patient going into ARPKD spectrum is very high. But however, I'll take it back. For the last year, I stopped saying that you don't see prenatal diagnosis of ADPK. There's a beautiful article published in NEGM with the gene involvement, and there was in utero bilateral enlarged kidney with truncated nucleation. And I was looking into one of the questions from Sushmita where she was asking for the role of genetic spectrum, genomic sequencing leading to the progression of the ADPKD or early manifestations. So most of the time, if you're seeing that, you are leaning towards more ARPKD. Now you have to be very careful with multicystic dysplastic kidney too, because hardly you will see that both together. I only have seen one case for the last 12 years. Has multicystic dysplastic bilateral, but keep that also in mind. But if it is bilateral, large kidneys, hyperechoic, you are leaning towards more into ARPKD. Very less % of chances you'll see ADPKD in utero at early manifestation.
Recently, like I'll just share a case and then ask your advice on it. Recently, we had a family coming in with no past history. First conception, and was about 23 weeks, and was having a bilateral echogenic kidney. the bilateral echogenic kidney on the higher side, and there were no oligohydramnios. Now in India, it was about 20-21 weeks, and in India, we are justifiably very worried of having children who will require long-term medical treatment, particularly like expensive treatment like transplantation, etc. So they had asked me that what should we do about this? Uh, but there was no oligohydramnios. The liker was quite okay. What will be your advice, Rupesh?
So that is something you have to see how the kids will progress. So a couple of things I'll tell you that oligohydramnios is not a dictum all the time with ARPKD. In the series, if you look, if it is really severe with the involvement of the liver or hepatocystic fibrocystic pattern, then you see almost 100%. But if it is a subtle ARPKD under progress, you won't see oligohydramnios as a universal feature. So you see that around in 50 to 60% of the patient. But the other thing is you have to be also be careful with other differential diagnosis, like is it involving into neonatal nephronophthisis, but in that case, the kidneys are smaller with a large echogenic disease. So the kid will define at the age of gestation how
But then,
it will be.
can I say that if you are not oligohydramnios, then the chances of you having a very severe disease requiring dialysis at the early onset is low, because in India we can manage once they are 10, 11 kilos. It is easier.
Right. So
Rajiv?
the mortality and morbidity is associated with the oligohydramnios is not, there is not a data on, or you cannot correlate oligohydramnios for needing the dialysis. The data is mainly for mortality and morbidity with ARPKD. But if you do not have oligohydramnios, your chances of leading any kind of dialysis will be pretty decimal or low. But if you have oligohydramnios, pulmonary hypoplasia, then definitely your mortality goes high and you need some kind of intervention soon after the birth. Sorry, I think Jalala was saying something and I...
Jalila, you want, yeah.
No, because actually I would like also to highlight the ARPKD registry from Max Libo from Germany, where I think few Indian centers are also participating there. So it is actually the same interface than ADPET-KD, but it is for ARPKD, and they have already 600 patients who are at follow-up. And he published, Max Libo, a very nice paper on this amazing registry. And actually in his paper, he demonstrated that when you have prenatally oligohydramnios or renal cyst or hyperechogenic kidney, then you have chance to have dialysis in the first year. I can send you this paper if you don't access it. I think that is the first valuable study with really big cohort of ARPKD, and we are now using it for.
Can I now put this question to you, Jalila? Like, so in this family, if they come to us and say that, so you advise whether we should go ahead with the pregnancy or not.
So they have oligohydramnion, Rajiv, or no?
They don't have oligohydramnios, but a bilateral hyperechogenic kidneys.
So what we are doing in our clinic, because bilateral hyperechogenic kidneys, we have few cases that, so we are doing genetic prenatally. We are doing a very quick genetic testing with ciliopathy genes, because you have these cases of HNF1 beta with really huge hyperechogenic kidneys prenatally, that they shrink at the first year, and then they became dysplastic, and you don't have any problem the first year of life. You have also these biallelic ADPKD patients. There is also recently a paper from Albert Ong, who described these patients with ADPKD biallelic PKD1 mutation. You have this case report of Gerson Bergman, as I mentioned, with these hypermorphic genes, and then you have ARPKD. So for ARPKD, it has been mentioned that no genotype phenotype mutations are known. However, with this big registry of Max Libo, he is now analyzing all these genotype, and I am really very curious, and it is coming very soon, and we will hear from this, because when you would do genetic, then you might maybe do a better counseling.
So,
To Rajiv's question, you cannot decide or help the parents to go or to terminate the pregnancy on that basis. And again, going back, there's two questions you have to handle. Nobody knows what's going to happen in a year because we have huge ARPKD patients. Now you're handling two issues here. Number one is what is going to happen at the birth, and are you prepared to provide them any kind of dialysis at that point of time? Or this patient is going to progress over the time, how the kidney cyst will evolve, will regress, or how the things will go. So when you deal with an ARPKD, you have to deal with two major things, whether you're dealing with the patient with pulmonary hyperplasia, with needing the vent, and then you have to do is immediately a peritoneal dialysis to preserve the life. That mortality goes very high. Now, if you have a patient with a bilateral echogenic kidney, and then you want to assess over a year how the things will go, that is a total different spectrum. And then you need a genetic help in that regard. Now, the chances of having the patients with ARPKD with no family history is pretty high, but I've hardly seen any severe ARPKD to just manifest and go slowly for 6 to 9 months. And then they will say in a 1 year, hey, by the way, I need dialysis now. ARPKD is brutal. It is hard. The mortality is high. And when they present, they have a severe pulmonary compromise. When you're dealing with just bilateral enlarged echogenic kidney, that could be a manifestation of severe other causes of ciliopathy. But if ARPKD, if fibrocystin is fully expressed, the morbidity and mortality is high, and they speak for it. ADPKD, I've hardly seen anybody with a young age. I have only 3 patients who come with a large kidneys. The other thing is the pediatrician needs to know if you have a kidney ultrasound length of 14 centimeters, which is so hard to convince them, you're already CKD3 per crystal in an adult. So length of the kidneys are very important too. So I think the question's answer can be divided into 3 parts. Number one is, if it is a manifestation of ARPKD, you need to ready for everything, including the involvement of the pulmonologist, involvement of the NICU and intubation and the peritoneal dialysis, which you can do in your country. Second is, if it's a bilateral enlarged kidney, the time will tell how they evolve. You never know that they need even dialysis or not. They do well. So those are the 2 things which is important. The third thing is, I was listening Jalali's lecture. Drinking 2 liters of water inhibits your ADPH, and that's been pretty well known by Dr. Schreier and his group. So it's not a new thing. And then also caffeine, cyclic AMP proliferates cysts. That needs counseling, need to be done too.
So we'll come back to this again just at the end of this other question, because I still haven't got my answer. But
your answer, I think, the fact that this child have no oligohydramnios, and how many PML, how many weeks?
Around 2021.
2021, I think you can wait and see, but you cannot do genetics, Rajiv.
We can.
So you can do genetics, and then you can.
But then, is there a genotype phenotype correlation? So we'll come. That was the second question. It is also in the chat box also. So Jalila, you can take it, and then Rupesh can add on to it. Is there a genotype phenotype correlation between in ADPKD and in ARPKD?
No and no. So in ADPKD, there is this huge intrafamilial variability, mainly due to several causes. First one, you can have in the same family other hypomorphic variants that you inherit from the other family member, or de novo in other things. second, we know that the cyst formation, the third hit, is very important in the progression of the disease. So someone who do a bleeding or an infection or ischemia perfusion, he can actually have a quicker prognosis than the other one.
But then the bottom line is that like just looking at the genotype, you cannot predict whether you want to terminate the pregnancy or
now
not.
there is actually there is this big
For your labs
center of breast where it is truncating, non-truncating, and KD.
Sorry, Rupesh, if you can mute your mic, please.
because you did not
Rupesh.
complete it.
Yeah.
So these breasts have shown this that when you have truncating mutation, you have a more severe phenotype than a non-truncating mutation. However, I think this week there is, I didn't read it yet in detail, but this week there is a very nice paper which appear with patients with truncating mutation and very mild phenotype.
So then bottom line is that we don't have, okay. At the moment, a strong.
They are PKD less, but I say Max Libaud is publishing now his paper, and I am really a part of it, but waiting for the results.
And Rupesh, if you're around, the next question is for you. Rupesh? Rupesh?
Yes.
Yeah, so this question was about measuring the total kidney volume. And
Yes.
do you, like, we know that ideally it should be done with MRI, but
No, that's not true. You can read the paper from that we had in
Nature.
Nature.
That was like when it was initially proposed, but now it has been done by ultrasound.
Yes.
So your comment on that, like how good it is, and secondly, like how much of expertise it is required.
It needs, so there is an ellipsoid model of calculating, and I can share you and you can share them. The model, it needs length, breadth, and height, and you calculate. Now, again, you have to also understand in kids, you don't measure the total kidney volume unless you're dealing with adolescent. So a couple of points I will tell it to you. That's what I was telling the people when we are prescribing these patients, because there is still no data except the first one we did with tolvaptan between 18 to 24. All of them are consensus panel speculations, which we sit and make the guidelines. If you have a kid whose ultrasound is more than 14 centimeter in just in length, that is already per CRISP trial, you are CKD3. Your total kidney volume is more than 650. If you have a young kid, 14 to 15, around 12 to 12.5, but if you have a kidney ultrasound, which is above more than 2 standard deviation, which you measure on the plot, you're dealing with progressive renal disease. There is no data that the tolvaptan is not for non-progressive ADPKD. I cannot write in US unless I prove it. It's a progressive renal disease. So criteria are total kidney volume, protein, hemorrhage, UTIs, kidney pain. So that's what the algorithm I'm showing. In children's, we don't know what will be your criteria for the renal progressive disease, and that's a big limbo in adults, so forget about it.
Sorry, and Rupesh, any comment on the diuresis, because that's supposed to be a big problem even in the adult?
Sorry?
Diuresis, like with tolvaptan, they start peeing a lot?
No, that we can discuss more, but the aquaretic side effect and lack of or withdrawal of the drug was only 6% in Reprise trial.
So you haven't found it as a major.
So the Reprise and Tempo 3-4, only 6% of the people, they withdrew the drug because of the aquaretic effect.
So nowadays you are happy with ultrasound measured total kidney volume?
That's what I do. Yeah, MRI is not going to get approved by the insurance.
Next question, I think we can skip. That's about the dose of tolvaptan in less than 1 year. I'm sure even Jalila is not using tolvaptan in less than 1 year.
No, there's no data, and I will highly recommend not to do that. Actually, you should not be using that less than 18 year in the USA so there's a case report for ARPKD which is published,
Yeah.
And at least in US, we are not going to
In-
do that unless the FDA tells us to do it.
Yeah, you are bound by FDA. Jalila,
Sorry, I have to go for the other meeting. So
Okay,
my
okay, okay.
questions, you can just forward it to Jalala.
Yeah,
Thank
and
you.
thank you, Rupesh. Thank you very, very much for
Thank you.
joining in. And we hope to get you in future also. Thank you very much. So, Jalila, in your study on ADPKD kids whom you tried tolvaptan, what were your inclusion criteria? Because I don't think that you want to share the outcomes because that is a surprise, right?
Exactly,
Yeah.
exactly. I want to come back. I want to come back. Now, actually, the criteria were from the age of 4 years till the age of 18 years, but we had a subgroup 12, 18, and then 4, 12. And why? Because actually the MRI was done only from the age of 12 years. And under 12 years, they had ultrasound for the follow-up because we were against anesthesia and weak anesthesia for MRI. And that's why there is this two subgroup, and then more than 10 cysts, I think, for the adolescent group, and a really diagnosis of ADPKD with a clear familial history.
So more than 10 cysts.
10 cysts
Was
for
one of-
the bigger, for the adolescent, certainly.
And,
Yeah,
and for 4 to 12 years?
I think we were with 4. With 4, if I remember it well.
Because surprisingly, we had a baby who, again, father had a ADPKD, which he didn't know, like it was discovered later on. But this baby in a fetus presented with hyperechogenic kidney. And then after birth was found to have polycystic kidney disease, and a genetic analysis showed ADPKD. So the father had this question, and then he heard about tolvaptan. So father had this question that would you want to start tolvaptan in this baby or not? And I sort of backed off. I said that it is not yet recommended.
Yeah. No. And actually, I must say that the adolescent, because I participated in this trial and I had 7 children who were treated, they were drinking 5 to 7 liters a day. They were peeing continuously. They were awake at the night 3, 4 times. So they need to realize this quality of life. But on the other hand, Rajiv, I was very, very surprised that I had 0 dropouts. That they all were motivated to do.
So at the moment, can we say that the best thing for these children will be good blood pressure control, good proteinuria control, preventing and treating UTIs, and that is sort of an advantage that if you diagnose them, then you are following them up more closely. If you don't diagnose them, then you can
absolutely
lose them.
Low salt, sport, and against BMI. That is also very important that we can do. And join the registry.
Any other questions from our panelists? Susmita Di, Jayati Di, anyone else? Subhankar? Yeah, there was one question. Susmita, you wanted to...
No, I just wanted to say thank you. I think this was a really useful seminar and really, cleared a lot of questions in our minds regarding the use of tolvaptan in pediatrics and the whole gamut of cystic kidney disease. Thanks a lot.
Thank you for listening and for inviting me.
And there was one more question: how to screen in early pregnancy with positive family history? I think we have already covered that, and you did advocate genetic analysis, but at the same time you said that you have to take it with a pinch of salt because you may not always have a strong genotype-phenotype correlation.
Exactly. Yeah, exactly. And I would really advise to read this paper of Max Libot because it was the first paper on such a big cohort on ARPKD, actually.
In India, like what I have found the problem is that most of the, like I don't know about Dr. Susmita Banerjee and rest of my faculties, but I have hardly, in fact, I can't remember, maybe one. I've seen only one patient, one child who had a family history of ADPKD and has come to me as a like we are suffering from ADPKD and I want my child also to be investigated. Most of my kids with ADPKD or suspected ADPKD have been found all of a sudden, like on a routine ultrasound scan, or on one child in fact was very interesting and presented at 12 years with a intracranial hemorrhage.
That is very rare actually, huh?
Yeah,
But maybe because they are not aware about the advantage, Rajiv. So you need to make patient days for information, because our population, we do a lot of patient days of our hospital to inform them the importance of getting this hypertension treated. And maybe that is an idea that you can coordinate with the adult.
So this was really sad because she presented at 12 years with intracranial hemorrhage and then became quite vegetative after that.
Oh my goodness.
And there was a family history of intracranial in the family also with ADPKD.
Yeah, that is a very rare case, Rajiv. You need to publish it, because there is really no or almost no intracranial hemorrhage in childhood in ADPKD.
Yeah, I tried to search that time, it was rare.
Yeah.
Susmita di, Jayati di, Shubhankar, any comment? Otherwise, we can call it.
Yeah, because I have indeed another meeting. So if
great, thank you very much, Jalila, and we would like to have you with us again, and hopefully in person, not virtual. Okay.
That would be a pleasure. That would be a pleasure.
Okay then. Thank you very much.
Thank you very much, all
Bye.
of you. Bye. Bye. Bye.